The indications to perform a paracentesis are to remove tense or symptomatic ascites, to diagnose new ascites, or for the evaluation of spontaneous bacterial peritonitis. One of the biggest risks in performing this procedure is related to site infection, or injury of underlying structures such as bowel, bladder, or blood vessels. There are 3 approved sites for paracentesis needle placement: the bilateral lower quadrants, approximately 5 cm superior and medial to the anterior superior iliac spine, and 2 to 3 cm inferior to the umbilicus in the linea alba. Here the ascites is denoted on the ultrasound image, where the dark space appears to have the intestine floating in it. The dark space is the ascites fluid pocket that you will be aiming for in your paracentesis. Also be sure to examine the skin surface to make sure that there are no vessels in the site that you will be penetrating. A pre-prepared paracentesis kit should be available at most centers and include the following equipment: a 27-gauge needle and 18-gauge needle or filter needle to aspirate lidocaine, 1% lidocaine, 10 cc syringe, a catheter over needle introducer, usually 6 to 8 French, an 11-blade scalpel, gauze, fluid sample collection tubes, and a drainage tubing with 14-gauge needle and vacutainer, or one-way valve tubing and a 60 cc syringe used for drainage with the plastic bag. Sterile gloves and a face shield should be worn for this procedure. Be sure to have the patient positioned supine with the area for insertion exposed prior to donning sterile equipment. In the absence of an overt bleeding disorder, routine evaluation of platelets and INR are not required, even in patients with cirrhosis. Often, patients requiring paracentesis have low blood pressure at baseline, and the removal of a large amount of fluid can precipitate worsening of hypotension. Limiting fluid removal to 5 liters can help reduce this risk, but severe hypotension should be addressed prior to performing the procedure. Once site selection has occurred with the ultrasound probe, cleanse the area with chlorhexidine or betadine, being sure to cleanse a large area and prevent contamination during the procedure. A sterile drape may then be applied, being careful to remove the adhesive backing that will keep the drape in place during the procedure. Persistent ascites fluid leakage following needle placement can be decreased by using a Z-track technique. This technique involves using laterally directed force on the skin as the needle is inserted, so that when the needle is removed, a continuous passage is not present, but rather the tissue pushes against itself to keep the passage closed. Draw up lidocaine from the vial, using a filter or other large gauge needle, into a 10 cc syringe. Place the 27 gauge needle onto the syringe and inject a wheal of lidocaine at the selected site. Puncture through the center of the wheal and aspirate as the needle is advanced to ensure no vasculature is penetrated. Stop when ascites fluid is returned, and inject lidocaine along the entire tract as the needle is withdrawn. Set up the collection tubes and catheter system while the anesthetic takes effect. Make a stab incision using an 11-blade scalpel at the center of the wheal site. Now, with a syringe in place on the catheter over needle device, pull traction as the needle punctures the skin and advance the needle through the stab incision. Continue advancing until ascites fluid is returned. Advance 5 millimeters further to ensure the catheter, and not just the needle tip, are within the peritoneal cavity. Keep the hand controlling the syringe steady. Now, advance the catheter forward. Do not withdraw the needle. Once the catheter has been fully advanced, the needle may then be